So I'll hand over to the urgent care RPIW team.
Hello, folks. How are we doing? This is our 90-day report out from our RAU work, which we did in ED at LGI. My name is Manu. I'm the lead clinician. This is a project form which we started sometime in November, and we had 6 weeks of work. We presented the initial round, and we took a bit of a pause, and then now is the final presentation. Now, if you look at the outcomes, we did the initial trial. We showed that it, as a process, it works. Then we did a 4-day trial where we showed the numbers work, and then we did a full 30-day trial, which started in January. And again, we showed we achieved all the challenges we were set out to. To reiterate, the challenge was the process time is reduced from 4 hours to less than 2 hours. We achieved 1 hour 54, and that's where we reached. Now, that is where our challenges started. Once we did this, we showed the system works. We were achieving what we wanted to achieve, and we achieved all what we had to set out to achieve. But in the meantime, it threw out a lot of issues. And because it threw out a lot of issues and lots of challenges within our team, we decided to pause it for about 4 weeks. And during that 4-week pause, we ended up massive engagement with all the staff and communication of what we were doing. And the feedback primarily from them was we were de-skilling a certain group of staff by moving the work to another group of staff. The requirement of a senior clinician at the front end, always available and supporting, was needed. And the feeling was the task load, or the mental task load of the clinician, was much higher. And as you know, ED, our attendances vary by time. The need of the patient varies by time, and the skill of the clinician and the staff varies by time. So all that caused a bit of a mismatch. We attempted to average it out statistically, but in reality, it didn't work really well. And it threw up a lot of challenges. And we realized, yes, we are trying to average out a system, but there's lots of variability in the system, and our process didn't accommodate all the variability. Now, taking all that into account, we decided, taking feedback from all the staff and the clinicians who took part in the trial, we decided another system called MEDRAT, or Medic at the front end, or Medical Rapid Assessment Team, would be the process to go forward. And after a lot of engagement, we started this in 4th of March. Now, once we started this, this is a model that's been tried in lots of different places and has not worked very well. And we have taken some learning from all those. And then we started the trial on the 4th of March. Now, this, as in the last 4 weeks, we've realized it's actually a more stable model. It is not driven by somebody being more enthusiastic or clinicians being proactive and pushing. It seems to work on a stable thing. It accepts variability. When I say variability, it accepts variability in attendances, which is what we have in ED. It accepts variability in presentations, which is what we have in ED. It accepts variability of staffing numbers we have. There are some days the staffing is good, some days the staffing is not good, some days the skill mix is different. So this system accepts all that variability. Despite taking all this variability, our ECS is improved by about 10%. Again, this is a time when we didn't really publicize that we are going to monitor it. We didn't push on a daily basis to say this is how we wanted it to run. We let it run organically. So all that was useful. Despite all that, an improvement of 10%, I think, is positive. For me, the bigger positive in all this was when we started this process in November, the team was a bit disengaged. The team was not happy for any form of improvement work. They felt all the improvement work arrived and didn't really leave any long-lasting improvement. And they felt the team was not involved in this. And for me, that is a big win. In the end of these 5 weeks, the team actually feel they would like to do a lot of improvement work. They're engaged. We're all thinking together, and everybody's happy to throw in ideas. And I think for me, that is a big win.
Manu, that's really, really clear. Thank you. We'll come back to some questions at the end if we can hold on to you for a bit. Is that okay?
Yeah, absolutely.
Fabulous. On to our next 60-day report out, which looks great. Okay, so around the really important topic of our healthcare acquired infections. So I'll hand over to the SIM team. Have we got Brad and Charlie with us?
We have, yes.
Great to see you.
Hello, my name is Charlie. I'm one of the matrons in IPC and one of the process owners for this work stream.
And I'm Brad. I'm one of the matrons in SIM and the other process owner for this piece of work.
So Brad and I are here today to present our 60-day report out. Just as a recap, we had the RPIW in January, in which we investigated the process for investigating. We reviewed, the investigation of healthcare associated infection. We all know that that currently is a root cause analysis meeting, and we throughout the PISA week, the rapid improvement process week, we looked at PISA and how we would be able to implement that, removing non-value added waste, but more importantly, ensuring that we have patient involvement at each stage of the investigation. We moved from RCAs can take a number of weeks to organise. There's that missed opportunity of learning, and obviously patient not being able to understand and find out what the investigation findings from their root cause analysis meeting. So it allowed us to have a timely review of the infection, and also put in place systems where further specialist input was required, and our new processes on there. So since we last reported out, we have continued with the PDSA cycles. We're on version 5 of the document. That they are stabilised. Really important to us is that we have continued to get MDT feedback throughout this process, and recently we adapted part of the process based on that. So that's a really important LIM value. We scaled up to the rest of specialty integrated medicine on the 18th of March, so that includes all the wards within SIM. We're also very lucky to have 2 cardiorespiratory wards join the pilot. They were L18 and 19. We've continued to attend various forums, governance forums, senior clinicians to discuss the new process. Again, we've gone live on the 2nd of April with the digitalisation of the second part of the investigation, which is our post-infection analysis. That went live on Tuesday on Datex. And we have submitted a request for work from our DIT colleagues to put the first part of the process, the post-infection pro forma, on PPM. So that's in progress at the minute. So I'll hand over to Brad.
Thanks, Charlie. So we've continued to collect some data over the last 30 days since our last report out across the 5 domains that we'd got some background data on before the week. The number of healthcare required infections, we still have a median of 8 per month. However, so we haven't had anything to be able to bring that down, but I think it's important to make note that we have seen a raw data decrease across the elderly care wards. For March, we only had 4 logged healthcare required infections. So there has been a decrease, but not enough for us to say it's significant over a period of time yet. We still think the delivery time has shown some big reduction from what we had with the old process. There are still some delays with that. We're attributing that to the backlog of the old RCA work that we are still working through, and that's evident with the wards that we've more recently gone out to trial on. They're still trying to clear that old workload. We've maintained some really good improvement on our morale metrics around are the right people involved and is the workload shared evenly between different members of the MDT. So we've gone back out to the staff that have been trialling the process, and we've had 100% positive response rates on do they feel the work is shared fairly across everyone, and are the right people now involved in the process, which is good to see that that's maintaining as we go through. And our documentation, as Charlie said, we're halfway there with digitalisation. We've got our Datex piece up and running for the second half of the investigation, and we're in the early stages of doing some work with the digital team for PPM as well. So we think we've now reached level 2, but there's still some there's some clear ways that we can still improve that with the work that we're doing moving forwards as well. One of the big things on the back of the process really has been the process allowing us to start to theme our lapses in care or issues that we find during investigations. And that will become easier through Datex over the next few months as data starts being put through that digital system and we can start using the dashboards. At the minute, we are still doing it manually, but we're able to identify themes of different infections and break that down by area or by infection. And in time, we'll be able to see that overall across the organisation, which has really given us some focus for our new action forum meetings to create some meaningful actions and feedback to the wards and initiate some change as well, which is good to see, which previously you had to look through each individual RCA, but over the next few months with the DATEC system in place, this should be done automatically and more accessible for everyone involved. So over the next 30 days, before our 90-day report out, we are having more of a focus on, part of the week was about a piece of work on prevention and patient involvement in education from admission on healthcare acquired infections. So we are going to do a focus piece of work on L18 and L19 and work that up and how we can then replicate that in the other areas too. We're continuing our trials of the action forums and our restructure of our CSU's IPC meetings to have a real focus on what are the issues, what are we doing about it, and going away and making that change with the clinical teams and then feeding that back in real time. We're still reviewing the level of harm attributed to healthcare acquired infections, and because we know that that's quite a large burden of work in terms of the DOC2 letter and requirement afterwards. So we're working that up with risk in the background. And we're also planning to recirculate our survey of the new process that we used originally to gather people's some more robust feedback and how people feel it could be further improved before a potential rollout further across other CSUs in the trust. And I think that is us.
Thank you.
Amazing, brilliant, really, that's come on brilliantly. Andrea, can I? Yeah, I've got Andrea. There we go. Yeah. Nice to see you, Andrea. I'll hand over to you. This looks fabulous.
Thank you. So you can see the summary of my project there and the aims. I'm Andrea Galley. I'm one of the clinical site managers. The title of my presentation today is going to be Patients Accepted Internally for Transfer, Working Towards One Version of the Truth. So it'll come as no surprise to say that demand and capacity planning can be really complex and it can feel like an impossible puzzle. So who does take priority? The patient from ED, the patient waiting to transfer out of critical care, the list goes on. Within this demand are some of our inpatients who've been referred and accepted by a different specialty. Without a timely transfer, there could be a number of issues and potential risks for these patients. The obvious clinical risks, the risks associated with an increased length of hospital stay and the impact on the mental health of this group of patients. And of course, never forgetting the morale and safety of our people who may be feeling out of their comfort zone and questioning if they have the required knowledge, skills and experience to care proficiently for their patient now. Next slide, please. As a CSM team, we have over a number of years tried to capture within our capacity meetings and reports this group of patients who are awaiting transfer, and we have attempted a number of tests of change to do this accurately and consistently. Next slide, please. So thinking about waste and then all the opportunities to convert this into value, 6 out of the 8 categories sprung to mind. I felt that having trust-wide oversight of this information would support with the knowledge of which patients were awaiting transfers, and having specific custom lists that captured this may reduce, even eliminate some of the waste. Next slide, please. The driver diagram tool really helped me plan and have clear oversight of the project. It made it all just feel more manageable and helped keep me on track in relation to what the original aim was. I've highlighted the path that led to the introduction of the accepted internal transfer custom list, starting with the high-level primary driver, visibility and ownership of the information, to how this could be made into a workable reality. As you will see, having key trainers to support others in using a custom list, having time allocated within the CSM leader standard work plan, and celebrating progress verbally and written format were all practical changes that it was hoped would then start to chip away positively at the aim and result in measurable improvements. In relation to balancing measures, the primary driver, influence over operational flow, links into contextual decision making and accepting that decisions around internal transfers are sometimes about taking one step back to move 2 steps forwards. I think that the diagram also demonstrates that quick fixes are rarely that. There are lots of operational and human factors to consider. Having a custom list is a great enabler for the aim, but not if nobody wants to or knows how to use it. Joint ownership of the change and its implementation with our patient flow teams was and is so crucial. Next slide, please. We were given the green light to create the list to capture this group of patients in August 2023, and it went live in October. There were about 6 of us who virtually got together and produced a quick reference guide. We continue to talk about the process and will shortly be moving on to the second iteration of this guide based on the most recent feedback from the PFCs and the Ops Centre team. Next slide, please. So thinking about process measures and the accuracy and embedding of the process, is the custom list accurate and contemporary? Because without this, the ability to reduce variation and waste will be limited. Is it one version of the truth? So not quite, but progress is being made. And I believe as teams are seeing its worth, the accuracy is improving. There were lots of unknowns with the YAS data. I was thinking that as we strengthened our processes in relation to internal transfers, were we better prepared in requiring less urgent YAS transfers, but there were too many variables to draw such a conclusion. Next slide, please. So the questionnaire, so linking back to the aim of enhancing the experience of our people. I couldn't have made the questionnaire any quicker and still needed it to be meaningful, but there were just 2 questions. When we started the Leeds Improvement Method Intermediate course, we had to say what our anxieties were, and mine was that I wanted the change to be helpful and not be change for change's sake, or even worse, than actually create a process that makes things harder for our teams. So far the feedback is really positive and will help shape our next steps. So thinking about those next steps, currently this custom list is a generic template and there is quite a way to get this tailored for internal transfers, but I'll pursue this with our digital colleagues. The specific headings would really help remove some of the rocks in our shoes. There is ongoing work with the wider Ops Centre team to ensure urgency of patient transfers is categorised, standardised and recorded within this list, and this work continues to evolve. The intention was not for patients awaiting LYPFT to be placed on this custom list, but the patient flow teams have started doing this and we all actually find it really helpful. So we'll have conversations about how this is incorporated officially, a really positive unintended consequence. Next slide, please. So linking back to the original aim of enhancing the experience of our patients. So I'll finish where I started, where I referenced walking in the shoes of others on that first slide. I asked our patient experience team if they'd noticed any changes in PALs, complaints in relation to internal transfers since commencing this change. The data looks really positive on the whole, and I hope that this work has played some part in influencing that. However, it is important to challenge our assumptions or my assumptions and my mental valleys, thinking specifically about this patient group and how easy it would be for them to articulate if they were upset or concerned. Not all patients can complain, not all patients have advocates who can speak up on their behalf, but we can and make change as a result. Thank you for listening.
Well done, absolutely brilliant, brilliant. So let's move on to our 4th one, and then so over to Susanna.
Hello, good afternoon now, isn't it? My name's Susanna. I'm one of the clinical nurse specialists in charge of the chronic limb-threatening ischemia service within vascular surgery. And I've been asked to come and explain about the no pre-assessment pathway that we have undertaken. We call it the NOPAC pathway. So chronic limb-threatening ischemia is a progression of arterial disease, which is essentially problems with the blood flow to the legs. There are other areas, but we concentrate on the legs. It can cause severe pain, ulcers, gangrene, and ultimately limb loss. There are 2 main ways of treating CLTI. One is open surgery, and the other one is with endovascular treatments, which are conducted in the interventional radiology department. In 2019, the best practice clinical care pathway for arterial disease recommended that we try and diagnose and treat our patients with CLTI within 14 days if they're on an outpatient pathway. Despite our best efforts, certainly post-COVID, we were continually falling short of this by some way, particularly with those that had been referred for endovascular treatments. Patients were facing waits of over a month and we were accumulating waiting lists. So we needed to look at where we could shave some time off this process. It was suggested that patients who were planned to have endovascular intervention may not need to go through a formal pre-assessment process, and we thought that if we were able to get rid of this step, it would most likely save time to treatment. There were conversations between radiology, anaesthetics and the surgical teams to agree that dropping the formal pre-assessment process for this group of patients was safe and in the patient's best interests. Once this was decided, there was collaboration between the vascular nurse specialist and the interventional radiology patient flow coordinator to create this pathway. A specific inclusion and exclusion criteria were drawn up and agreed between all the interested parties, and we created an uploadable form so that the relevant safety checks carried out by the referring clinician were documented on PPM. All patients undergoing endovascular treatments require 5 full days of MRSA decolonisation. This would have ordinarily been dispensed in the pre-assessment clinic as part of their appointment and was one of the main reasons to go through this formal pre-assessment appointment process. We arranged for the relevant medications to be dispensed directly from the outpatient areas under Chapter 15 of the LTHT Medicines Code using a 2-nurse check. We were then able to drop the pre-assessment step completely. We initially started within the CLTI clinics, but very quickly expanded into the diabetes limb salvage service at St James's, as they have a similar patient group. We immediately noticed that patients were receiving booking dates for IR much sooner than before. We began in June 2023, and between then and the 1st of October, we were able to save 34 pre-assessment appointments. The patients on the NOPAC pathway had a referral to a treatment time of 16.5 days. The patients in the same time frame who were not on NOPAC had a referral to treatment time of 61.87 days. This is a difference of 45.37 days referral to treatment time. This pattern was seen again in the following 3 months, October to January. The overall numbers were smaller in general and the referral times were better. However, we were still able to see a saving in referral to treatment time of 37.5 days, with the average referral time for those on NOPAC now being 10.06 days. One thing we did see was the number of patients who did still go through the formal pre-assessment process were often being referred for legitimate reasons, such as those patients on warfarin. We don't include those on the NOPAC pathway. Others were referred on a non-urgent referred basis. So we're now seeing that the majority of appropriate patients are now on the NOPAC pathway, certainly within this patient group. The things that went well was that the openness to collaborative working was a particular success. It required input from the surgical, pharmacy, outpatient and IR teams. None of this would have been possible without the support and hard work from Aldrin Soriano, who's one of the IR patient flow coordinators, who's been absolutely instrumental in getting this off the ground. There was clear understanding from all involved that there would be a definite benefit to the patient if it worked, as well as improving waiting list times. And as I say, the improvement was almost instant. So considering what I think is the overall success, I'm not sure I'd do very much differently, but there are some lessons learned, certainly when rolling out a project like this. And the main one is that constant communication is key. I'm still finding the odd clinician who is unaware of the process, and then keeping up with staff rotations is also important to ensure that they are aware of the pathway and the uptake continues to be high. So we've started to implement the process in other areas such as MSAA, so we can reach even more patients. There's one slide missing, isn't there? We're also going to try and roll out into other areas. Aldrin is hoping that this can be used, so it can be used across the board within IR for other procedures, not just the lower limb stuff, and he's currently working on a formal PPM form to streamline the process further. I'm also aware of some other work being done with the laser varicose vein patients. Thank you.
Susanna, that was brilliant, and well done for handling that where you lost your slide. You clearly know it, Susanna, inside out and back to front, so well done. It's brilliant to see the Leeds improvement method being used around our competing priorities, around reducing those waits for patients, and great to see it applied in the space of learning and safe care. So let me open it up to colleagues on the call. Feedback for 4 amazing presentations would be great, and of course any questions as well. So let me open it up. Gillian, great to see you.
Hello everybody, hi, Gillian Hodgson, Deputy Director of Infection Prevention and Control. I'm not actually going to talk about the HCAI. I think one of the things that's struck me as I've listened to all the presentations is communication, communication and communication. And even when you think you've done that, it still hasn't perhaps reached where it needs to. I do have one question, if that's okay, Manu, because listening to, and thanks ever so much for your honesty. You know, these projects are hard. You know, you think you're making a difference, and everybody has had the opportunity to share their voice and their views, and then sometimes you find that that's not the case. So my question to you is, if you were going to give me one piece of advice, words of wisdom, in terms of what's the difference that you made when you went back and approached the second time that got that fabulous result from your staff, where they felt listened to, valued, in fact are just revved up and raring to go on the next project?
Just to say, open and honest. Say some things don't go right, and be open and honest and say it didn't go right, and explaining why we didn't take on board certain suggestions. Not all the suggestions are lovely in their own mind, but us formulating and going back and saying, I didn't take that on because this was the reason, and explaining that back to the team, I think helped. Bottom line, listening and the team feeling listened to. I think that was important, or rather, to phrase it in one word, empowering the team.
Great. Brilliant. That's really,
thank you.
Really helpful. James?
Some fantastic presentations, and just wanted to say, Andrea, love the critical reflection in your presentation, and particularly what you were saying about starting to use it for LYPFT patients. It's interesting how one good idea can lead on to the next and the next PDSA. I really like that. And Susanna, phenomenal results from the NOPAC pathway. And really like that you're thinking about the spread of this approach to those other areas, because you know, the benefits for those patients are absolutely fantastic. So well done. Made my Friday lunchtime.
Brilliant. Thanks, James. Okay, it's just past 1. I'm going to share with you, in the same way as communication came through for you, Gillian, tenacity came through for me, and determination, resilience. So I really liked the story that all 4 told, and that I can see us just keep PDSAing. We're realizing that's a really important part of our improvement process, aren't we? And just seeing your metrics, not just the patient benefit, but also lovely to see the metrics from the staff morale perspective as well. So congratulations, everybody. It's brilliant to see you using the Leeds improvement method in your daily work. And I really applaud you for that, and thank you. Good to see everybody. If you're not working this weekend, have a fab weekend. If you are working with this weekend, I hope it's not too bad. Lovely to see everybody.
Take care.